I hope I can give a little back now that I'm going to talk about atopic dermatitis and psychiatric comorbidities, and this will be on anxiety, depression, sleep disorders, and attention deficit and hyperactivity disorder. These are my disclosures, and one of the things when I started out with looking at this was actually that it's not a new idea. It's something that we have been discussing for a long time. And I found this study from 1976 from the American University of Beirut, where they looked at the psychological profile of patients with AD. I'm sure that all of us who works in the clinic have a special impression of these patients, how they are compared to other subgroups like psoriasis patients. There's certainly differences in their personality. And what they find here in this study, using something that I really cannot say what is, the Eisenach personality inventory and something called the manifest anxiety scale and so on and so forth, but they conclude that atopic dermatitis patients tend to be in a state of high manifest anxiety. They're depressed, neurotic, and hypochondriac. I think that's being a little bit harsh saying it that way, but there is data today that actually will support some of this, but probably the wording is a little bit different. There's a lot of literature that has come out recently, and they all agree on the facts that they do have an increased risk of having a depression. They have increased prevalence of suicidal ideation, suicide attempts, and also suicide. They have an increased risk of attention deficit and hyperactivity disorder. I'll show you the data. They have more sleepless nights. That also includes the parents, of course. If anybody here has a child with AD, you know how it is, and you know that some nights are very, very long. They have an increased risk of anxiety in the sense that they feel all of this all the time. They don't do the everyday job. I'll get back to it. And they have an increased use of anxiolytica and antidepressants. But this is not special for atopic dermatitis. I think it's so for most of skin diseases that they do have an increased risk of affection of their psychological well-being, and it's something that may have been underappreciated for a while, but it's something that I think that we are becoming more and more aware of, and it's something that we take into our daily clinical practice. Now, what is the connection to AD? And I think it's complicated, as they say. If you look at AD and the psychiatric diseases, there's a lot of roads that leads to Rome. They may have an altered self-image in the sense that they do not have the perception of themselves as a whole personal being. They find themselves disgusting. They have all of this itch. So that in itself can lead to depression, but it also leads to social isolation. You don't want to go to the parties. You don't want to go to meetings. You don't want to go anywhere because you feel disgusted by yourself, and you have this perception that other people will also find you disgusting. You don't go to sports. You don't go to the swimming pool. And this, in turn, also leads to, again, depression and anxiety. But it's also something that can lead to loss of career opportunities. If you don't go to the job interview because today my eczema is too bad, I have eczema all over my face, I cannot concentrate, then in the end, you may not get the job that you really wanted to. You may not get the education that you wanted to. You may not get the wife or the husband that you wanted to. And all of these things may also lead to the depression, anxiety, and psychological symptoms. Sleeplessness as a result of the itch that comes with AD is also one of the things that can add to this loss of career opportunities. If you're too tired to go to school, you don't get the education that you want to, again, you don't go to the job interview, you're maybe not performing very well in these situations, and all of this may also lead over to the psychiatric diseases. And then in the end, we also have inflammation, which in itself may actually also affect the brain and thereby the psychological, psychiatric well-being. And I'll try to go through some of these when we look at the studies that has been done so far. I will talk about the association with depression, with anxiety, with suicide, attention deficit and hyperactivity disorder, and also a little bit about the inflammation and how it may be possible for this to precipitate psychiatric diseases. If you look at AD and sleep disorders, children with AD do have a longer sleep onset latency. That means that it takes longer for them to fall asleep once they go into bed. Again, we have all tried to sit with a child who doesn't want to sleep for 1 hour, 2 hours, 3 hours. We're singing, we're reading books, everything. It ends up with us sleeping and the child being completely awake. But that's normal, I think. But in atopic dermatitis, it's something that's a problem. It's something that happens day after day, and it's something that actually also affects the child's well-being, because when you go to bed, you want to sleep and you want to be safe and sound. They have a greater sleep fragmentation in the sense that they wake up. We've all seen this. There's a small clip of a child who's itching all the time. So we all go up and down in our sleep pattern, going from deep sleep up to the REM sleep and going down again. But they're more fragmented. They wake up more often, so the quality of the sleep is lower. And the efficiency, it sounds stupid to talk about efficiency when sleeping. Everything needs to be about efficiency these days. But it's actually very important that when we sleep with a high quality and we sleep efficiently, so that the brain it's something with the washing out of all of the things that we get resets. And these children also have greater difficulty in waking up, which may be a problem. If you're in a busy every day, the child has to go to school, they're not waking up, they're in a bad mood, and this again leads to a lot of confrontations with parents, with other people, other children at school or in kindergarten, and this may also affect their psychiatric well-being. And we know that sleep disturbances is a major factor for some other diseases, and also these sleep disturbances which are caused by this itching during the night. It's linked very highly to attention deficit and hyperactivity disorder. It's linked to obesity. It's linked to hypertension. So this actually also talks into Jacob's speak that there might be other factors than the inflammation and AD itself. It's the disease that may affect other things that again is a risk factor for cardiovascular diseases. But it's absolutely sure that these things are affected by sleep disturbances. Now, depression, what is it? Because we can all say sometimes we feel sad, but a depression is something else. You lose the interest in all of the activities, and you lose pleasure in activities that you once enjoyed. You can have changes in appetites, which can lead to weight loss or weight gain. You can have trouble in sleeping, so it sort of bites itself in the tail. Loss of energy, you're tired, and you have maybe more purposeless physical activity, and you're feeling worthless and guilty. And that is probably, and it's not like I sometimes feel when I see a patient. It's really something that affects you profoundly, in the sense that you might feel that you are the cause of the children dying in Africa, and it's really something that goes deep in and makes you consider whether it's really worth living. You can also have difficulty in treating or concentrating or making decisions, and then you have thoughts of death and suicide. So this is not a nice thing to suffer from. You have all of these complications, which also speaks into some of the other diseases we've heard. You can have obesity, which can lead to heart disease and diabetes, pain, physical illness, alcohol or drug misuse. Again, we are talking into the cardiovascular diseases, anxiety and panic disorders, family conflicts, socialization, suicidal feelings, self-mutilation, and also premature death from other medical conditions. So overall, depression is not something that you would wish for. And then you have AD on top of it. And when you look at it, how is the connection between atopic dermatitis and depression? There are these two studies, the National Health and Nutrition Examination Study from 2005 to 2006, and the National Health Interview Survey. And if you start over here, you can see that the odds ratio for having a depression overall when you have AD is almost the double. But it increases as the disease increases. So if you have severe AD, the odds ratio is increased a lot more. Even on a lifetime odds ratio, it's almost double those that are controlled, those who are healthy, who do not suffer from atopic dermatitis. But not as we saw with the cardiovascular diseases. The numbers, the real numbers, are actually quite high. If you look here, there were 344 who, on a questionnaire, said that they had atopic dermatitis. And out of these, 109 scored high enough to have the diagnosis of depression. It was exactly the same down here. If you look at here, you have 2,500 patients who reported that they had atopic dermatitis, but of these, 670 actually reported that they have signs and symptoms of depression. So it's something that matters. It's not a rare thing. It's not 1 out of 10,000. It's really a lot among these patients. So it's something that you need to consider when you are seeing atopic dermatitis patients. This is a study from Denmark. if you look at it, what they did was that they used the registries and they looked at atopic dermatitis and psoriasis. And if you look at AD, you can see here that overall there was 1.57 in odds ratio for having a depression, and this was even more so in AD with severe disease as defined by the use of systemic drugs. Because, again, this is registry studies, so we cannot see if they had a score or an easy score of this or that, but we can see that they have used systemic treatment. They also used antidepressants more, and again, this diagnosis was also taken from the registries. And the thing is, we don't know, again, if they really had a depression or if this is depressive symptoms or they had depressive thoughts, but they're registered as having this. And you can also see among them there was an increased risk of having anxiety, but also the use of anxiolytica. Using these gives us a more complete picture because we can use the prescription database, and there we also register what the GPs are prescribing to these patients. We cannot see the diagnosis from the GPs in these registries. And it was quite a large study. There were 80,000 controls and about 8,000 people with atopic dermatitis. So all in all, it really is a risk, and it increases the use of psychiatric drugs. These studies have been confirmed again in other studies. There's this study from the National Health and Wellness Study with 75,000 adults from the US, and out of these, 428 had self-reported atopic dermatitis. Here they had 37.2 reporting symptoms and signs of depression versus 20.9 in the controls. Same finding in a smaller study of 36 adolescents, so it's also teenagers. And there's a Korean study which actually lands in almost the same on the digit number as the Danish studies, showing that out of 1,517 patients, you had an odds ratio of 2.25 if your disease was severe of having a depression when compared to the control population or the healthy ones. So it's not something that's limited to Europe or US. You also find it in Asia. So it's a worldwide problem that depression is associated to atopic dermatitis. How about suicide? Because I said that it was something that's part of having a depression. Now, we have these different things that we talk about when we talk about suicide. There's suicidal ideation. That's when you have thoughts of committing suicides, that you're considering, maybe my life is not worth living, maybe I want to be dead. How can I commit suicide? You start planning it. Then you have suicide attempts, and that includes both those which is serious, where you try to slide your wrists or you jump in front of a train but you miss. But it's also if you consider, or if you do take, say, vitamin pills, because you're not going to die from taking vitamin pills, but the fact that you took them in order to take your own life makes it count as a suicide attempt. And you have aborted suicide attempts where you stop, where you have the pills, you're almost taking them, or you have taken them but you make yourself throw up. So all of these things are part of suicidal thoughts and attempts. And then you have suicide itself. There's a great debate in Denmark right now because it's really a problem. In the US, it's the 10th leading cause of death. So it's not something to be taken lightly. And if you look at the study, they're not so big, but there's a study of 146 patients who suffered from mild to moderate eczema, not even severe, and of these, 2.1% had suicidal ideations and 2.7% wished that they were dead. In a Danish study, we had 18.9% with suicidal ideations, thoughts of ending their own life, versus 6.8% in a control population. A German study of 62 patients found almost the same numbers, 16% having suicidal thoughts. And there's a British study also showing that there's suicidal ideation which correlates with the severity among the patients, but also the parents. So it's something that's affecting the families also, that they have this child who is suffering so much that it even makes the parents think about suicide. You wouldn't think that we are talking about eczema. We are not talking about a severely handicapped child or something like that, but it's something that matters very much in people's lives. Anxiety, not the anxiety that Kierkegaard was talking about. That's something completely different with the dizziness of life. But this is anxiety where you, for a period of at least 6 months, worry too much in a healthy way. You have tensions, you worry about everyday stuff, things that you cannot change, things that would not worry any of the others, and you have these feelings of apprehensions, you have physical symptoms, autonomic arousal symptoms, sweating, increased heart rates, you have symptoms from your chest, you have symptoms from your abdomen, you have symptoms from your brain and your mind, you can't concentrate, you feel unable to do everyday tasks, and you also have sort of general symptoms. And there's a study here with 1,519 patients, whereof 689 had mild disease, 830 had moderate to severe disease. And here you see again that 51.2% suffered from anxiety and or depression. So they took this one in versus 27. So it's double up on patients who suffer from this. And they show in this study also that the depression and anxiety, to a certain degree, also depended on the control of the disease. So if you can control your disease by treating it, the symptoms of anxiety and depression gets less. And there's also a Swedish study on siblings and in twins, of twins who have, where one have AD and the other has not. And there's an increased risk for the twin not having atopic dermatitis to have symptoms of anxiety and depression. And there's no difference between the monozygotic and the dizygotic. So it's not a genetic explanation. It's probably something about living together with a sibling who is chronically ill and suffering from this disease, which takes a lot of attention and which is very unpleasant. So all in all, if we look at depression, it is associated with depression, and the numbers are high, and it correlates. The severity correlates with the risk of depression, and there's an increased risk also of anxiety, also among the siblings, also among the parents, and that anxiety also correlates with the severity of the disease. And there is a risk of suicide and suicidal ideation among these patients. So it's something that we as clinicians ought to be aware of when we talk to our patients. If we get the suspicion that they might have these thoughts and they might be threatened for suicide, I'm sure that in all of your countries you have emergency lines that you can call. We have that. We have things that we can give as counseling to these patients. Now, we have attention deficit and hyperactivity disorder, something that we also did some work on. I'll just show you a few of the slides there. But what we're talking about is it's one of the most commonly diagnosed psychiatric diseases among children, as is AD one of the most commonly diagnosed skin diseases. It's surrounded by a lot of controversies, so I might say something that you find is not okay, but I'll try to keep it as scientific as I can. But we differentiate between these three types of ADHD: inattention, hyperactivity, and impulsivity. Inattention is something where you can easily be distracted, you cannot focus on one thing at a long time, you easily get bored with the task, you have trouble in completing your homework. Hyperactivity is you cannot sit still, you talk non-stop, and you touch everything, and you cannot do silent tasks. You may be, if you go down to impulsivity, impatient, inappropriate, show of emotions. You cannot wait for your turn in games. It sounds like my son when he was 5. He's a teenager now, so it's completely the opposite. But for these, it's a problem. For my son, it wasn't, because I couldn't make him make his homework and so on. But for these, it's something that has severe implications in their daily life. It stops them from going to school. It has implications in the way that they play with the other children, the way that the family works. So it's not something that's nice. I once heard somebody say that, well, this is just what we in the old days called ants in the pants. But it isn't. It's a disease. And if you have ever met somebody who suffers severely from ADHD, it's really a psychiatric disease with a lot of consequences for these patients. And we don't want to talk about the AD, but the deprivation of sleep is one of the most known factors, or one of the most strongest factors affecting the development of ADHD. And we know that the sleep deprivation is prominent among AD patients. So there's a lot of studies on this, and we have questionnaires and we have cross-sectionals, and all of these indicate that there's an increased risk of attention deficit and hyperactivity disorders among these AD patients. This is a study that we did. We identified a population from 1995 up to 2010 who had received a hospital diagnosis of atopic dermatitis. And we can identify these through a CPR number, Social Security number, or whatever you want to call it, but it's something that's unique for everybody who's born in Denmark. And then we have all of these registries. We've heard so much of them over today. We have a psychiatric central registry where we register all psychiatric diagnoses. We have the Danish National Registry of Patients where we diagnose all patients made in a hospital. Has Statistics Denmark where we can see educational level, we can see how much they earn, we can see what color their pants have. No, we can't see that. We have the Danish Medical Birth Registry where we can see when they're born, if there's some defects, and we have the prescription database where all prescriptions made out by doctors is registered. We can also see if the patients actually bought the medications. We can't see if they took it, but we can see if they bought it. So all of these were used to do this study on ADHD and atopic dermatitis, and you can see here, these are ADHD medicational use, and this is the diagnosis. You can see here it's higher for the medicational use, but that's because we also have the general practitioners, and we cannot see the diagnosis here, but you can see there's a statistical significant difference between the children with AD and the healthy controls, and the risk of developing attention deficit hyperactivity disorders. The numbers are here, but I would really like to go on and show you that we are not the only ones, because there's this table here which Uffe Nygaard made, and you can see there's a lot of studies here, and almost all of them agree that there is an increased risk of ADHD among patients with atopic dermatitis. Whether it's due to sleep loss, whether it's due to something else, is still unclear, but it seems to me now that we don't need to discuss whether or not there is an increased risk, because there is. This was the study from Denmark. Finally, I'll just touch lightly upon inflammation itself. Does it play a role? Because we know that there's cytokines that shows a dose-dependent relationship with depression. Interferon gamma treatment, for example, increases the risk of depression. When you use this drug, you need to be aware of whether the patient has earlier had depression or whether they have depression in the family. The cytokines can cross the blood-brain barrier and lead to something that you might call a leaky blood-brain barrier. It's nothing to do with other diseases where you talk about leaky things, but it does open the blood-brain barrier for more permeation. And in that way, you get more cytokines into the brain, and these can affect the synaptic signaling through affection of the microglia, the supportive tissue of the brain. It can affect the metabolism of neurogenesis, and the inflammation itself may actually also affect the ACTH and cortisol concentration and lead to glucocorticoid receptor insensitivity. So all in all, you can see here, this is from a very nice review that I would really recommend you to read, where you have different, they look at the skin overall, but you have inflammation here. And this inflammation leads to an effect on the nervous system. And again, you have all of this chronic inflammation feedback. And over here, you get this stress that leads to the leaky blood-brain barrier. You have an increased oxidative stress, decreased neurogenesis, so you're not making new synapses, and you have an increased activity in the microglia. So all in all, it does affect the way the brain works. And psychiatric diseases comes from the brain. So the inflammation itself, although I cannot give you any more explanatory models, affects the psychiatric well-being of these patients. And therefore, we probably also see that the more severe your atopic dermatitis is, the higher the risk of having a psychiatric disease is. So with that, I'm come to the conclusions. We can say that there's an increased risk among these patients for depression, for anxiety, for attention deficit and hyperactivity disorder, for suicidal ideation, attempts, and even for suicide. It does not, as we have also discussed with other diseases, warrants that we should not, screen all the patients with AD that comes into our clinic for whether they have psychiatric diseases or not. But we need to have a clinical observance. We need to be aware that this is an increased risk, and we need to see this in the patient. So if we sort of feel alarmed, then it's probably because we are alarmed, and it's probably because it's something that we need to explore more about the single patient. And we might see in the future that inflammation itself is a causal part in the development of these psychiatric diseases. And again, I would not make the case that you should treat the inflammation of AD to prevent them from having psychiatric diseases. I think you should treat the inflammation in AD to treat the AD, and thereby perhaps also, from all of the ways that you can get to these psychiatric diseases, prohibit these. So with that, I would like to finish. Thank you very much for your attention.